We are recording. Okay. Thank you very much, Becky. Um, so I think we'll start with introductions, and maybe we can start with Amanda and Dr. Concepcion to start us off tonight, and then we'll introduce ourselves and students.
That sounds good.
Okay.
So my name's Amanda Bartnick. I'm a registered nurse administrative supervisor. So what that means probably in the private sector is like a nurse manager. So I'm a nurse by trade, registered nurse. I've been in the nursing field since 1998, so a long time, and have worked in a variety of roles and capacities. The last 13 years, though, in particular, I've worked in nursing leadership, either as a supervisor or a manager level. And I'm coming to you tonight from Isanti, Minnesota, where it is bitterly cold and it's getting colder. So we're just snuggled in at the house here. And I am so impressed with Erwin tonight. He generally is not in a tie. So now we can hear from Sir Concepcion.
Thanks so much, Amanda. And it's always a pleasure to co-present with Amanda and definitely to be working with Amanda. I already had the tie on today, so I figured all of that effort should not go to waste. But she's right, I normally don't wear a tie. I'm Erwin Concepcion, a psychologist by training, been with the state for quite a while as well, and moved up through supervisory management positions. Currently, I'm one of the executives as a clinical services director, where I oversee the practices of social work, psychology, mental health professionals, behavior assistants, LEDCs, and a few others there, rehabilitation, OT, and RT primarily. Um, and so helping with clinical treatment that we provide. So Amanda's going to be providing the majority of the presentation this evening, and I'll focus in on those clinical treatment program aspects that we provide.
Wonderful. Thank you both for being here tonight. I'll start with introducing myself, and then we'll allow our students. So I'm Katie Kerr. I'm the program director for the MHA program as well as the HIM program here at the College of St. Scholastica, and I am in Mora, Amanda. So just north of you a little bit. Um, all right. So I'll just maybe start. I'll call out Angie. You're at the top of my list here, so we can start with you.
Sure. I'm Angie DeBruzzi. I currently work at Fairview, three different sites in the interventional radiology as a supervisor. And our organization does have mental health services. In fact, we just made a new empath unit in Edina. So that's the most recent one we've done.
Great. Thank you. Becky.
I'm Becky Keyser. I live in Paynesville, Minnesota, right between St. Cloud and Wilmer. Just started a new position at Essentia Health as the health information supervisor. Um, I do believe Essentia Health has mental health services, but I'm not exactly familiar with that at the moment because it's only my third day, but more to come.
Thank you. All right, Patrick.
Hi, I'm Patrick. I'm currently a case manager with Ascend Services, which is a community mental health organization in Duluth, Minnesota. And my organization does have mental health services, including case management, ARMS, and psychotherapy. So.
Great. Thank you, Patrick. And welcome, Dominic. Could you introduce yourself?
Yes. Hi, everyone. My name is Dominic Ramchek. I am originally from Minnesota. I grew up in Blaine, northern suburbs, and then moved down here to Arizona, which is actually where I'm at right now. I don't work right now. I'm in dental school full time. I did work for a consulting firm called Accenture before dental school, and I worked with some healthcare clients there. Um, but my school, they do have mental health services. They definitely emphasize it. It's available for all students to use. You can use it on an app or go see a therapist or counselor in person.
Great. Thank you. And last but not least, Nate.
Yes, you guys all know me. My name is Nate Meyer, cohort one student, finishing up with Amanda here in a week and a half. Currently in Duluth at Ecumen Lakeshore as a clinical quality coordinator, so quality work, scheduling, hoping to get into hospital operations here in the next couple months. That's my next pivot. We don't have a ton of mental health services in long-term care. I think that's a really big blind spot in what we offer. Not only I think in northern Minnesota, but in general, I think it's something that kind of flies under the radar in terms of long-term care, which is unfortunate. So we'll just be really lovely to hear from you all tonight.
Great. Thanks, Nate. All right. So with that, I can turn it over. Amanda, do you want me to drive? I can sure forward the
Oh,
slides. Okay.
love, love, love for you to
Okay.
drive this side.
Okay.
Dominic, are you originally from Blaine? I'm in Isani, Cambridge, Isani, and I went to St. Francis. I'm just curious if you hailed from Blaine all the time.
Sorry, what was your question?
Oh, I just was curious. You said you're originally from Blaine. Were you there for quite a few years?
Yeah, I was raised there basically. I went there all through Blaine High School. Yeah.
Okay. So I went to St. Francis, which is just north of Blaine.
Oh, nice. My cousins live up there in St. Francis.
Okay. Yep.
Yeah.
Yep. Love that. Cool. Okay. So Erwin and I are here tonight, and we are representing ourselves from the state of Minnesota. So the state of Minnesota operates inpatient mental health and substance use services. So we were under the Department of Human Services in the past, but as of January 1st, we broke off, and that's a legislative action that has to take place. And we are our own entity of the state, and it's called Direct Care and Treatment. And then we have 4 arms in direct care and treatment. So we're going to come to you and talk to you from the Mental Health and Substance Abuse Treatment Services Division. So go ahead and advance, Katie. And like I said, we already introduced ourselves. So there we are in living color. So a couple of questions. Did you know that the state operates 24/7 healthcare facilities? I know Nate didn't know when we first presented, and Erwin and I have subsequently presented, I think 4 times. And I am in cohort 1 and ready to graduate. So the state does operate 24/7 healthcare facilities. We have hospitals that we operate, psychiatric hospitals, along with residential service lines as well. All are secure facilities, so meaning the doors are locked. Our patients are committed to us from the Commissioner of Human Services. And so we'll get into that in a little bit more detail. But we're located all over the state. Does anybody have a pulse on where we have some of our facilities across the state?
Isn't one north of Duluth?
So just south of Duluth, actually, Carlton, Minnesota has one, and that's an all-female program. I actually support that site. Yes,
Anoka.
Yep, Anoka has a large facility as well. Used to be called like the Anoka State Hospital years ago, just
St.
south of
Peter.
Anoka High School. Yep, St. Peter has one as well. Yep, absolutely. And so we'll get into more of those too in a minute. And so, are you aware of who they serve? Do you have any pulse on what the okay? So we'll get into that as well. And then do you kind of have an idea of people that we hire? We hire nurses, we hire doctors, OTs, RTs. We hire clinicians, other clinicians, mental health specialists, behavior analysts, dietitians. We basically have a complement just like a regular hospital would. So we'll get into that a little bit more. You can go to the next slide. So we operate 6 hospitals. Well, technically it's 8. So we have 6 community behavioral health hospitals. Those are in Rochester, Fergus Falls, Annandale, Alexandria, Bemidji, and Baxter. It's all 16 beds. We have a child and adolescent hospital that's out in Wilmer, Minnesota. So Becky from Painesville, you might be familiar with it. It's right off of I'm not the Wilmer girly, but it's right off the highway. So pretty easy to find. And then our one of our largest ones that's a 95 capacity is the Anoka Metro Regional Treatment Center right on 7th Avenue in Anoka. We have 3 intensive residential treatment services, kind of what you would think of as a residential level of care. So I can't remember what your name is, but I bet you probably are seeing Patrick, perhaps, might be seeing folks coming into his services that were previously in an IRTS, IRTS. We love our acronyms. So we have 3 of those. We have 1 in Wilmer, we have 1 in Brainerd, and we have 1 in Wadena. And then we have, this is actually, I will update these someday, Nate, in my spare time, but we have 3 community addiction recovery enterprises. So those are co-occurring facilities that treat substance use and mental health. We talked about the one in Carlton, we have 1 in Fergus Falls, and then we also have 1 in Anoka. So those are all of our facilities are secure. They're all locked facilities. Go ahead, Katie, you can go to the next one. So this is an aerial view of the Anoka Treatment Center over on 7th Avenue. They technically are licensed for 175 beds. They don't have that many beds. However, they are expanding. They have a 50-bed new facility that they're going to begin construction on. I'm hearing in the spring. Erwin might have more info on that. But generally, they have a census of 95 with a waiting list of probably 95. Those are all adult patients. They're civilly committed to the Commissioner of Human Services. So there's a court proceeding that happened where the patients are deemed to need inpatient acute psychiatric stabilization. And so then they would be, generally they're usually in the jail system or in other hospital systems and go through a commitment process, and then they're sent into one of our facilities. Since 2014, we have had an influx of admissions straight out of jails. Rarely do we get a patient from MHealth Fairview or Alina anymore out of their mental health beds, or even Essentia in Duluth. Normally, most of our patients are coming from the jail setting, and that's likely because they've committed some sort of a crime, and then they need to be able to get some education to be able to stand trial for those charges. There is legislation around that in legal laws that require us to take those admissions within 48 hours as best that we can, find a bed for them. And those influx of jail admissions have really displaced our other patients that we perhaps may have taken from our other hospitals across the state. And then about 30 to 50%, it kind of waxes and wanes. Our patients don't meet criteria for stay, so they're ready to go to places that maybe are in the community, People's Inc., Ascend, like you talked about, other areas of service where they could be served not in a hospital or not in a residential setting. So we can go to the next slide. This is the look at inside of the treatment center there in Anoka. This is an older picture. They now have their enclosed nursing station right in the front there. Previous, the nursing stations were not enclosed, but with the acuity of the patients that they serve, they have enclosed those nursing stations. I'm sure you've seen, the news over the years, not necessarily us, but I know St. Joe's was in the news for a while with a lot of, or even in your ERs. You can't walk into an ER now and have a non-enclosed type of situation or a metal detector, those kinds of things. So we've increased our environmental safety as well, just like our private hospitals have. And so we are accredited by the Center for Medicare and Medicaid Spending, so CMS, lots of rules and regulations around that. And then we bill for those federal dollars as well. So that's kind of where the payment part comes into it. And I know you guys have been working through different classes with your MHA program on like funding and compliance and quality and those kinds of things. So all of our hospitals are CMS accredited, and most, actually I should say now, are all also Joint Commission accredited. So that's huge. In the past, the treatment center in Anoka was not, but they newly got their accreditation, I think this year. Okay, we can go to the next slide. So these are community behavioral health hospitals. These are those 16-bed units. They're across the state in those areas that I talked about: Alex, Annandale, Bemidji, Baxter, Ferguson, Rochester. These are short-term acute inpatient psychiatric services, secure facilities, only admit patients that are civilly committed. It's very rare for us to get a patient who is a voluntary patient. Most of the people don't want to come to treatment. That's not their jam. They probably likely have had many failed treatments throughout their course of their disease process. And then all of us are licensed by the Minnesota Department of Health, and that gets a little confusing, right? Because we are the state. Like, what do you mean Department of Health licenses you or surveys you? There are different branches to state government. So Minnesota Department of Health will come in and do surveys related to making sure our units are clean and our refrigerator temps are checked and we're passing medication safely, patient rates, all those kinds of things. And then we have the CMS and then the Joint Commission certified as well. You can go to the next one, Katie. This is the outside of the Child and Adolescent Hospital over in Wilmer, also 16 beds. And this is an update. They are budgeted fully now for 16. In the past, they were only budgeted for 8. So there is a little bit of a change there. I'll tell you, census today, I think, is 9 out at Child and Adolescent Hospital. They have some pretty acute little people that they take care of. I think that they have a 6-year-old right now who's given them a lot of trouble. Just is very, very ill. So these are, this is a beautiful facility. If you ever get the opportunity to come out and tour one of our facilities, or, looking for a job in one of our facilities, this is a great facility. They have a really great team out there. So they focus on mental illness along with trauma, neurocognitive, neurodevelopmental disorders. And we've done a lot of work in the last year with more intensive training related to adolescents for this program in particular. I supervise our nurse educators, and they have done a tremendous job with training up staff for some really niche types of things that these kiddos need for us, or we need to take care of. Again, Joint Commission accredited, CMS certified, billing for those federal dollars, and that's kind of how the payment process works. The state is like appropriated, so the legislature gives us a certain amount. We're a public entity, right? So we're not a nonprofit. We are appropriated dollars that we spend then on staffing, building, all of those kinds of things. But then we bill for the federal dollars to go back into the general fund, if that makes sense. This is the inside of the child adolescent hospital. This is their day room space. So they have those little circular cubbies you can kind of see. The kids will sit in there. They like those kind of den type of areas. They do have an open nursing station. That's what you're seeing on the left-hand side. Causes a little bit of trouble sometimes. They really have to make sure there's not things on the desk for the kiddos to kind of climb over and grab from a safety perspective. But this is kind of an intimate snapshot look of what that facility and what that unit looks like over at CAB. Okay, go ahead, Katie. This is the bedrooms. So you can see on the right, the picture on the right-hand side, the bed is kind of lofted and it's fixed in one place. It's not a movable bed. And then underneath is storage and cubbies. And then that little stool you're looking at is weighted, so it's super heavy, so they're not going to be able to pick it up and throw it and or move it or set it on top of themselves. And then there's like beanbag chairs for them to sit on. The picture on the left is like a day space area or a group room area. Similar, everything you can see is flush mounted. We have to really watch for ligature risks. So a ligature risk is a tie-off point for someone to be able to strangle themselves. So all that hardware has to be flush. All of our door handles you can't tie off on those. Same with the toilets, sinks, those kinds of things. We really want to limit from a mechanical perspective as well as a psychological perspective the ability for someone to harm themselves. So if it looks like a little bit bland, it's because it has to be, right? You can't have things jutting out for them to hurt themselves, run into, or try to tie off either. Okay, you can go next one, Katie. Thanks. This is our facility out in Wilmer. This is the Minnesota Specialty Health System. 16 beds as well. They're in Brainerd, Wadena, and Wilmer. They really focus on mental health rehabilitation. So really from a continuum of care, our patients will go into the hospital setting and then they'll transition into a residential type of a setting. So this would be another option for them. Think of it as a step down type of opportunity for them. Really aiming at transitioning clients into the community. So these clients will be able to go out on a pass. They might be able to go with their family for a weekend. They may even have a part-time job or do some volunteering, really focusing on community integration because we know that folks cannot live in a hospital system for the rest of their lives. Long are the days where we have these large state hospital facilities that are housing 2,000 patients. That's not where we're at from a person-centered standpoint. We really are trying to get folks back into their community, back into their homes, stabilize their mental health and substance use, and help them to have long, healthy lives. So you can go next one, Katie. This is another just saying that the health system, that Minnesota Specialty Health System, is licensed as a supervised living facility. That's a designation under the Minnesota Department of Health. They have an IRTS variant, so intensive rehabilitation treatment services. So there's just a little bit of set of rules and regulations with that. If you want to Google 245I in the statutes, you'll get more information on the rules and regulations, paperwork, compliance, those kinds of things. But still accredited by the Behavioral Health, by Joint Commission under the Behavioral Health designation. Go ahead, Katie. This was a picture of one of our bedrooms, patient bedrooms out at our facility in Wilmer. That facility has since suspended services. So what that means is we are no longer getting funding to be able to operate all 5. We used to have 5 CARES. They're called Community Addiction Recovery Enterprises. We previously had one in St. Peter and Wilmer. From a budget perspective and needing to shift things a little bit, serve more patients in our hospital setting, we had to decrease our capacity in our residential service line. So, but we still have 3 other care facilities. The Carlton one that I talked about, all females, and generally they will admit pregnant females as well. And the other 2 are co-ed units in Anoka and Fergus Falls. Census is 16 at those as well, and generally with a pretty long waiting list. And they really are focusing on the acute mental health has been stabilized in our hospitals. Now we're really focusing on the substance use portion of their treatment, right? So you have to, everything happens in a bubble and in the vacuum. You can't just tease those out as well as you would think you could. They really are co-occurring. So we really have to damper down those mental health symptoms and then really ramp up our treatment on our substance use disorder. So that's what these facilities in particular are doing, our care facilities. Go ahead, Katie.
Amanda, can I ask you a question quick?
Yeah.
How vulnerable is this program to changes in federal funding, or is it mainly, the state legislation that you're watching?
Very, very vulnerable to federal funding as well. Yes, absolutely. Because the state will get those federal dollars and then they will disperse. So I would say we've had years, and I've been around for 27 of them, and Erwin over 30, I think like 33, where we've had some pretty lean years where we've not gotten a lot of great federal funding and have had to make modifications to programs. And it seems like we might be starting into that season again here coming up. So we'll kind of see what happens. But our staff are so committed to serving as many patients as we possibly can, as quickly as we can, and getting them on to the next area where they need to focus on. But great question, Nate. So our care facilities are also supervised living facilities, also under MDH, CMS, Behavioral Health for Joint Commission. And their specific statutes are 245G. So they have the chemical health treatment program has quite a few different variances related to statute for those patients. So it is kind of interesting. Their staff training is different. They have to have things quicker for their staff training. We could just say more paperwork and kind of things that need to be attended to from that chemical dependency treatment program arena. So you can go to the next one, Katie. So I'm going to transition and let Erwin talk a little bit about this. Is kind of he is the clinician by trade, and this is his bucket. So I gave you a high level of like who we are and what we do. He's going to talk about the treatment that we provide, and then I'll talk about like staffing and things like that. So I'll mute myself and let Erwin chat.
Mm-hmm. Thanks so much, Amanda. I wanted to go back to a couple of things that Amanda said. Amanda, you did a nice job setting up the population that we serve, folks who are committed. It's a real big difference from the large campuses that we had 30 years ago with 2,000 people. I think the old term that used to be used was warehousing. And warehousing meant that that the public really believed that these individuals with mental health problems belonged outside of society and in places where they could be cared for. With the whole transition over the past 30 years of deinstitutionalization, one of the things that I want to highlight is our current mission. Our mission is to support meaningful lives through specialized health services others do not provide. So all of you are working for and will likely work for healthcare systems that are in heavy competition for patients, clients, billable hours, services. Your quality means a lot, not just for the safety of the individuals that you serve, but also because you even compete against each other on how safe you are and ratings and quality of care. For the state, we don't have the same pressure because we're actually serving people that nobody else can or wants to serve or is able to serve. And so when you think about that, I highlight that because due to our mission, we have individuals who have to come to us from the courts. I bring that up as part of programming because you can imagine that the people that we specialize in are people that want nothing to do with treatment. They don't want to be there. They don't care to be there. They don't think they have a problem. That may be because they're too ill, or that may be because they've already been through the system 100 times, not found it helpful or valuable, and just want to get out. For folks who are heavily addicted to substances, there are those cravings and urges that drive them to want to just get out from where they're at and be able to use again, be able to cope in ways that they feel like they can cope, which is often with substances, or as we sometimes describe it, self-medicating. So think about that as your population, people who want nothing to do with you. And then let's talk about the treatment that we offer. This is core 4 here. And so we have 4 engagement strategies that our medical director, Dr. Kylie Stevens, had formulated some years ago. And so we're still in the process of implementing this. But we have motivational interviewing, we have positive behavioral supports, trauma-informed care, and I know that there's one that I'm missing, but I can't see what it is that I'm missing here.
All the positive behavioral supports.
No, the one at the top left. Person-centeredness. Person-centeredness. I can't see it, but then I couldn't remember, like, what am I missing here? Person-centeredness. So all of these contribute greatly to being able to know the person, not just the disease, get to understand their needs, what they really are when they're feeling better and healthier, not just what they tell you when they walk in the door, which is, I want to get out of here. But to really get to understand their preferences, who they are, and what they're really looking for in life. So how to help create a meaningful life. With that in mind, our safety is also at stake. And so one of the things that we have to train our staff on is the understanding that the more and the better that you can engage the people that we serve, our patients and clients, the safer they are. Patients and clients who trust you, who understand why you're there, who see that you're there to help them, not just for a job, are much less likely to act out or strike out or take a swing at you. Now, if folks are psychotic, confused, heavily paranoid, that may not do the trick, but more often than not, that engagement will help you. So our programming is all built on at least being able to start to work with people slowly using one of these techniques. And then next slide. So on the left side, the core 4 really involves these items, the approaches that I mentioned earlier. And by the way, I'm hoping that you guys are seeing more trauma-informed care no matter where you are. Some people are learning motivational interviewing, some people are not. You guys talk about patient-centered treatment or care because you want to have options. The bigger your menu is for wherever you're at, the bigger the menu is for the treatment options you have, the more likely you are to not only capture that patient population, but their satisfaction as well, because you did it in a way that fits what they're looking for and the outcomes that they want. But that trauma-informed care probably cuts across so many different areas because it's one of the ways that we prevent re-traumatization. One of the things that we've not talked about is that a real challenge for our staff is when we do have aggression. Sometimes it reaches a level of imminent harm, either to themselves or the staff or other patients, and individuals may have to be secluded and restrained. We never like doing that, and it's a high bar to reach before we do that because we know that folks are probably going to be re-traumatized. It's probably happened to them before. They don't want to be touched, they don't want to be handled, and yet if they're really unsafe, then we may have to do that. So the more our staff understand trauma-informed care, the better job we can do of preventing that and finding out from folks what can we do before a crisis reaches a level where they can't really manage their behavior. And then on the right side, you have some of the actual treatment modalities. Medication management is a huge one. And again, when you realize that some people may come with severe, all of our conditions that people walk in with are pretty severe. So it's not adjustment reactions. This is deep depression. This is huge anxiety. This is paranoid or delusional thinking that's just almost fixed and stays there even when they're being treated well and they have good treatments. And so medication management is a huge one because that oftentimes for most people will help them pretty quickly. Although, because they're coming from jails and other places, they may not even be medicated for months and then come to us and we get an order. Because of our ability to commit people in forced treatment, we can also get forced medications in some cases from a judge's order. And so we'll undertake that. Illness management and recovery for folks who've worked in IRTS programs, or if you worked in ACT, or some of those community-based mental health systems, you know that there's this illness management recovery that is research-based, showing that the more that people can manage and can understand their condition, understand what helps them, advocate for themselves, and manage their own condition, the more likely they are to reduce the number of hospitalizations or prevent hospitalizations altogether. So we really try to provide those skills, education, and therapy in that way. And then, of course, everything that we do is based on assessment. There's diagnosis and treatment. But our folks, I'll tell you right now, our folks are really complex. The reason why they're coming to us from where they're coming is because other folks have not been able to be successful, or they've landed in the legal system. And so the ability to understand multiple diagnoses and medical conditions, because I would say that our staff, our professionals would say that our patients are coming in sicker and sicker each time from medical conditions, diabetes, high blood pressure, skin issues, poor self-care, poor health care, lack of access. Many of our folks have been homeless for many years, and so that comes with some co-occurring medical conditions as well. And so we probably see some of the most complex individuals that we have, and certainly some of the most vulnerable in the state. And then we have, Amanda described some of our special safety issues built into safety areas built into our environment, but we also have tons of safety training and awareness that we practice for these individuals. We know that many of them are at high risk for self-injurious behavior, as well as suicide attempts or attempts to try to get help and communicate in unhealthy ways that can be very dangerous for them, whether that involves cutting or tying something around their necks or doing something like that. And then, of course, we have various forms of therapy, everything from dialectic behavior therapy, DBT, CBT, skills building, behavioral therapy, and supports to help individuals rehab. And nursing do a nice job of really looking at some practical applications of treatment and skills that can help people. And so we have a whole variety of things that we provide. Again, the challenge is our staff have to work through this difficult situation of people not wanting what we have to offer. So over time, we've tried to enhance our engagement strategies and the menu of things that we offer. The whole idea behind comprehensive treatment is to be able to offer something that somebody's going to connect with and want and benefit from. So you have to offer several things, knowing that most people will only gravitate towards one or two. But if you don't do that, you won't capture or engage most of the people in your treatment. So that's a high focus for us. Next slide. And then I would stress that these things can be used interchangeably. I think we're now in a world where we're moving away from people asking, well, which one do you want us to use? Do you want us to be person-centered? Do you want positive behavioral support? Should we be trauma-informed? I think that's old ways of thinking, but we're still educating our staff about how to do this and how to do it seamlessly and how to provide people what they need when they need it. So I think you can tell that the skill levels and the demands that we put on our staff are increasing over time. From 30 years ago, 40 years ago, warehousing people and just having eyes on for safety, to engaging, treating, finding out preferences, hearing their story, retelling that story to a team so that other people understand better how to work with them. The whole time, our people that we're serving are becoming more complex in their needs. So a lot of training, more and more training is going into this. Amanda mentioned very quickly that some of the people she supervises are the nurse principals, the nurse trainers, and that has always been an important job and becoming more important all the time, because we almost can't keep up with the new information about strategies and approaches for how to work with this population. And those folks are key to capturing the attention and interest of the staff so that they participate in those things and learn new things. The idea that you could be a nurse for 30 years and you knew it all is out the window, or any professional, because you have to be prepared that in the next couple of years, there's something that's going to be proven more effective that we have to switch to. And behavioral health has been far behind the medical areas in advancing their approaches. It takes us even longer, decades longer sometimes, and that has to shrink and shorten so that we're really using the best approaches we can for folks. Next slide. And then, is this where you pick it up, Amanda?
Yeah, I can totally pick it back up. Erwin hit some really good points. Doing a humanistic approach of simply building rapport and just like checking in on somebody and just like, how's your day going? What do you need? Some of the most basic things that you and I can do without a problem, or we can engage our families with, like, this is just what we do. That is where we have to start. You have to start at the most basic humanistic level, because some of these patients are coming from a jail setting, Erwin said, probably unmedicated, and they're either very aggressive, or they really want to hurt themselves, or they really want to hurt you. So, giving them some time and some space to acclimate, and providing some routine and providing some structure and reassurance, the things that just we all need as a human being, are the same things that they need. And then we build up from there. Because they don't have a choice. They are committed, and they're ours. And they walk in the door at Baxter. It's like, okay, hi, here's your bedroom, here's your sheets. Like, would you like to eat? What can we get for you? Those kinds of things. It's all, you really have to start kind of at that Maslow hierarchy of needs with these folks, and then build up it from there. And we do have some really high success rates. We've got some patients that are very ill, and our staff can do an amazing job with getting them ready for their next setting. They're no longer hearing voices. They're no longer talking to people that aren't there. Those kinds of things. We can do a lot with medication management for sure. So that's a huge part of it. So HLOC is hospital level of care. So those are our hospitals. We have staffing. We have some really great staffing. We have administrators that run the hospital, and then we have nursing supervisors. We have clinical directors, and then we have like a secretary. I did put acronyms on here, but I'll just spell them out real quick. And then we have social work, occupational therapy, rehab therapy, mental health program, mental health professionals, MDs, medical doctors. We also have psychiatric APRNs and medical APRNs, and then behavioral analysts. So those folks are kind of a Monday through Friday, but work some evenings, work some weekends in our hospital setting. And then we have nursing staff that are 24/7. So registered nurses are assessing our patients. We have licensed practical nurses, and then unlicensed staff, which are mental health program assistants and human services technicians. Our hospitals can take 24/7 admissions to do assessments, kind of get them in the door, get them snuggled in, start some meds, those kinds of things. The nurses can do that on their own with an on-call structure to a physician to get orders. Our care programs and our MSHS programs are a little bit different. They're residential line. They don't have to have an RN there all the time, but they do still have a complement of nursing staff that are there. They also have administrators, nursing supervisors. In our care facilities in particular, we have licensed alcohol and drug counselor supervisors and licensed and alcohol drug counselors to be able to do that treatment that Erwin was talking about. All of our staff are trained in Core 4, all areas of that, but we have some of our elevated professionals that really kind of dig in more and are able to work more in the treatment plan with our patients. So I share this slide because people don't realize the amount of people and the type of people that we employ. So I'm also here as like, hey, if you're looking for a job, now you know Erwin and I, and then we know Nate, so you can just like reach out if you're looking for something. So I purposely put this in here. I'm always recruiting. Okay, next slide, Katie. And so then we also have regionally based staffing. So I'm a regional staff, so I go all over the place. It's not uncommon for me to go to Rochester or go up to Baxter or go to Wadena, and travel around based on the need. So we have advanced practice registered nurses that do that. They cover multiple sites. We have one that goes to Carleton on Monday, and then on Wednesday she goes to Fergus Falls and sees patients. Our nurse managers, which is what I do, our nurse educators are regional. We have regional substance use disorder clinical managers and mental health professionals that travel. It's not uncommon to see Erwin out and about doing an assessment. He's an executive, but he also still sees patients. So it's very exciting. We have regional dietitians, we have safety and security staff, infection prevention, quality and risk, operations, social work, and pharmacy. So all of those folks can deploy to the sites. When we have a survey come in, it's super fun because it's like the Avengers assemble and we go where we need to go and we get through the survey and support the staff. So we have regional based staffing as well. Next slide, Katie. Oh, that's all I have. So, okay, questions. I can't remember. The last time we did this was in May. We do it twice a year and it's always like, how is it already December? And then I just wasn't sure if we were coming or not. So what questions do you guys have for us?
I have a question.
Yeah.
So first of all, super interesting presentation. I can relate to a lot of things you said. I have a couple different experiences in acute psychiatric facilities. I worked at HCMC in their inpatient site, and also spent some time at Essentia in Duluth at theirs. I was just sort of wondering, from your perspective, what do you see as, or like what is your opinion on the current state of the whole like mental health system as a whole, and like the biggest opportunities for improvement?
Well, Erwin talked about this a little bit. So we serve the patients that can't or won't be served by other private facilities.
Correct.
And that's because, you know, they want them in a bed for 5 days and they want them out. You're not treating somebody for 5 days, but I just say this globally. The private sector is tied to the financials, right? And they want the billable dollars and they want to turn those beds over as fast as they can. We have the opportunity to actually take our patients and like spend time and really treat them to the fullest that we possibly can. So it's kind of a loaded question, Patrick. I mean, there's not enough beds. Yeah, not enough beds. And for the beds that we have, the private sector really is trying to treat and street. I mean, my son works in the ER in Cambridge, and has been, and now he's at medical school in Duluth. But the amount of people that they are boarding in those ERs, or the folks that like actually need something, but there's no lever for the ER to pull, but give them give them a benzo and give them a shot of Haldol and send them on their way. There's several things that are fractured in the healthcare system overall. And I do think that we see our mental health patients all over. You see them on your cardiology floors, they're in your ortho floors, they're all over. So we have to get better about treating. In my opinion, it's the most important thing to treat. And then we can focus on, cure the heart attack or all those. Well, that's just I get a little soapboxy, so I'll quit talking and let her talk.
I was gonna mention, Patrick, are you still at HCMC?
No, I'm not. I left there in August.
Okay. Oh, so not very long ago. I used to work at HCMC. No, Dr. Colon over there. So there's the contrast exactly of what Amanda provided for public institutions. The private or even other public healthcare, HCMC is a great example. That payer mix is largely Medicaid, Medicare, and the hospitals are drowning in debt from Medicaid, Medicare. I know Dr. Colon is really concerned about that there's lack of equity in the payment and reimbursement for mental health. So that's a huge factor. If you're ever in a place where you're managing a department or a hospital or some part of healthcare, behavioral health and substance use treatment is a real drain on your dollars. Your cardiac is supporting it. Your ortho surgeries are supporting it. Neuro is supporting it because it is just a huge hole of endless debt because they're not getting reimbursed. It's not equitable. Payments aren't the same. So I know there are a lot of hospitals where they really do struggle. And if somebody's got to be in there longer than just a handful of days, right away it's just down the drain for payment for those hospitals. Oftentimes, since the jail, it's really since the jail admissions from jail, it's really soured a lot of those hospitals on being able to use the state system because they all got pushed away with jail patients. And so where the Regents Hospital, HCMC, North Memorial, and every other hospital in the state could depend on sending somebody to us and having them admitted if they weren't going to recover quickly, they can no longer do that. So they're eating even more costs by having people even another day or two or three or a week longer. Sometimes they're there for months. Fairview has had situations where they have a patient for 200 days, and I'll tell you that is a huge drain when nobody's paying for that. So I think I'm a glass is half full person, and I see part of my mission, our mission with the state, is really providing some alleviation to that whole system. But I know if you're on the other side of the fence in one of these other hospitals, it is not looking good in terms of those that cost for that population that's being served.
Gotcha. So, I guess going off of that, I was sort of surprised to see, like, I guess how small the capacity was of some of your facilities. And I know that, um, is that because of a lack of funding that, or a lack of something else that sort of limits the capacity of those?
Well,
Because I know that there's the demand for those beds.
yeah. And so the state leases these hospitals, those ones that I talked about in Baxter, Bemidji, and they only have literally 16 beds. So, and that is, and we had more throughout the years, but it's really hard to hire staff for, say, Fergus Falls, Wadena, in these 16-bed facilities. So there's some of it with the hiring, there's some of it with the staffing. There's limits on we don't have the space anymore. If anybody's familiar with like the Brainerd campus or the Brainerd Treatment Center out on 18, that used to be a huge campus that housed 2,000 patients. And so where we've moved from as a system and as a society and as a state, from large warehousing patients into smaller settings, acute stabilization, and moving on, the theory is you shouldn't need that many beds. Okay, but that's really not practical because we do need more beds. But then they'll still have to be funded somewhere. We still have to be able to staff them. We have to have the operations to support them. So, could we get more beds? We would love more beds. They are going to put 50 more at that Anoka Metro Regional Treatment Center that was approved by the legislature, and they're going to start that construction. So that's great. But it's still 50 enough? That's always the question. We see some pretty, and the substance use, I think, is a factor. When people are using heavy substances, that really turns on some serious mental health issues. So it's a very big problem. And we're always full. So just know that our beds are always full. If we have a discharge today, either the admission's coming today or the admission's coming tomorrow. If we have a cap on any of our facilities, Carleton's a great one, for example, because they're under construction, we have to take some beds offline. That is a dynamic conversation. That's like, when is it going to be back online? Who's the contractor? When are they coming in? What's the problem? Let's go. Because we need those beds.
Mm-hmm. I was just going to say, Patrick, I heard you also coming from the point of like, do we not have enough money to have bigger facilities or more beds? Here's the trick. When we went from large campuses, and maybe Amanda will remember the terminology. There's a term for when the feds are off the hook for paying. It's like an institutional something.
Yeah, there's the 16 bed that's a reason to. There's a IDDT or I can't think of it. There's some rules on
how big
maximizing.
Yeah, so if you actually go beyond 16 beds, the state is 100% responsible for the payment. If you hit 16 or less, you share the cost with the feds. So we did two things back in 2005. We shifted away from huge campuses that got no support from the feds and was all on Minnesota's dime. And they were also not accessible to case managers or families because they're in these faraway places, to having more smaller facilities where families had easier access to their family member. Case managers could come visit and do case management easier. And we decreased the size so that the feds share in the cost. The feds didn't think that was fair, but it is a rule, it is a law. So we benefited by having smaller programs closer to home and sharing the cost. So we actually got 3 benefits out of it.
Cool.
Great question, Patrick. Really good.
Is
Angela?
it hard to find staffing?
It can be. In some of our remote facilities, when I say remote, I mean greater Minnesota outside of the metro. Sometimes we can have a hard time. I have an LPN vacancy in Carlton that's been there since May for a licensed practical nurse. May. So that shouldn't be too hard to find. We have an RN vacancy, registered nurse, from July. So we're working on it. So if that gives you any idea, sometimes in our professional, I would say, and Irwin can speak to this, our professional staff, our licensed alcohol and drug counselors, or our mental health professionals are a bit harder to attract. There's a pay differential between the private sector and the public sector, us being the public sector. People aren't always like, well, dang it, my benefits are so darn cheap, so I really do not need to make $50 an hour. They don't really, or pensions, when you're hiring a 19-year-old, they're like, I don't care about my pension. What's a pension? So it's some of that dynamic too. So sometimes you become a little bit of a salesman to say, you should care about your pension. People don't get pensions anymore,
Yeah.
Go ahead, Erwin.
And Angela, you're in a highly specialized area. And I think we see the same thing, that the more specialized that we want to hire from, the less likely that there's a pool in outstate, because they're all in the metro. They went to big medical centers to study. They got their degrees and they did internships and fellowships and residencies. So very few of them actually want to be out there in the rural health. That's why it's so great to see rural health training programs where people are starting off with folks who want to be out there. But we struggle in my area. Some of our highest level degrees are neuropsychologists, and there's not very many for the whole state. And so we do have to be able to provide some tele for neuropsychologists to do interviews, feedback, but we still have somebody on the road a lot driving to do the actual face-to-face testing. But if we don't provide the ability to do some tele, we would never get a neuropsychologist. They're just not going to be living out there. We do have the newest one we hired is at Brainerd 2 days a week for our TBI specialty program. We have a brain injury specialty program that's at Ertz out there, which is really cool to have somebody there in person 2 days a week working with and training the staff alongside the clinical work that she's doing. But yeah, it's hard to recruit in some of those areas.
Thank you.
Go ahead, Becky. Go ahead.
Do you have like do you work hand in hand, or do you have like people come in or anything from like clergy or spiritual leaders or anything like that? Do people ever question that? Like, can I get
That's a great question, Becky. So at our treatment center in Anoka in particular, they actually have a chaplain on staff full time, and I think they might even have a part-time one too.
They do have a couple part-time. Yep, they've built up that department.
Now, in our greater Minnesota sites, though, Becky, that is an opportunity for us. So we do try to have, like, if we can, have volunteers come in and those kinds of things. But I would say that's it's pretty limited. That is a missing piece of the holistic care.
Yeah, well, I'm glad to hear Anoka has it, because I the whole concept of this honestly scares me, and I thank God I've never had to experience it. But you feel so bad for those people,
Yeah. And nobody is immune. I mean, I used to work with a nurse, and he's always like, you're just one cheeseburger away from being on the other side of the desk. You don't know. You could have an MBA where you suffer a TBI. You could have some sort of a traumatic event on a bus line. There's just a lot of different things that could happen, and you just don't know. So I hear you on like supporting them from lots of different angles in a holistic approach with whatever they've got going on.
I think one of the things also we're getting an increase in diversity of the individuals that we see, and so it's not just chaplaincy, but it's really spirituality in general. So we're really now focusing more on equity, which means smudging for individuals who are Native American. And so that's all building up in our system as part of our treatment program and wellness programs. We a couple of years ago hired a wellness director for our area, and she continues to look at equity and what does that mean for both the staff and the patients we serve.
Yeah, that's another question. Do you guys offer because it's got to be really hard taking care of these people. Do you offer like emotional and psychiatric support for your staff?
Yeah, so we have an employee assistance program that offers lots of different things. We have counseling for staff that they can use. Lots of different benefits as part of your benefit package that are just like free, right? So you can call a number and you can have 5 free counseling sessions, and then they can develop a treatment plan for whatever you need after that. I think that's a great point, Becky. We work very closely with human resources to be able to support our staff. We offer Family Medical Leave Act just like they would in the private sector. The new sick and safe time is also something that we have as well. And then I'm sure you've heard a lot about it, the January 1st that's coming out with the, it's kind of like FMLA 2.0. I can't remember what they're calling it.
Paid Leave Act.
Yeah, the Paid Leave Act. So lots of different things for our staff. And we've had to use those before. The EAP folks have some really great counselors on their staff. And we've had them come into our facilities before. Like we'll just, EAP is coming today. They're going to be posted up in this room. They're also going to come to our shift reports. They're just going to help us kind of process what happened on the unit last night. Very common for us to be able to use EAP in our facilities. Great questions. You guys are so engaging. I love it. And you have presentations to do tonight. Wow, you got it. You got it. Katie, did you have a question too?
I appreciate it.
I was just kind of wondering about readmissions. Is that a thing you guys deal with? Yeah. Okay.
Yeah.
I wasn't sure with your limited beds and all that if you see a lot of that.
Yeah, because they're still under that commitment status, probably. Okay. So after discharge, they likely still have their commitment for some are 6 months, some are a year. We just set a referral that needs to come back in.
Got it.
Sitting in a different setting, and we have to prioritize admission. Yep, because they're so committed to us.
So they kind of jump to the top of the list then, Amanda?
They're priority. Okay. Yeah, then they're triaged as priority admission. And if they are a substance user with an IV drug use, those are also priority admissions. Again, this is all like statute determines these like readmission criteria. But pregnant IV drug users for sure are top of the list, readmissions, under commitment. And that's why sometimes we can't get those hospital patients in, because we have these other patients that are the priority admissions for us that we have to take first. So that's why they sit at, North for a long time, or HCMC or Fairview or whatever.
Okay.
Gotcha.
Yeah.
Can I ask one more question?
Yeah, I was just going to say, any more?
What is a behavioral analyst?
Oh, Erwin can take that
one. I'll take that one, Amanda. Now, actually, it's really good. We are some of the few in behavioral health to actually use, and I have to say we don't use behavior analysts because they just started a licensure that was passed within the past, I think, a year ago. Where you have to be licensed as a behavior analyst to call yourself that. And it is somebody who's an expert. You typically have a master's degree now if they need to be licensed. And their whole specialty is understanding how to do an assessment, how to do observation, how to do data collection and debriefings and graph data in a way that they can understand where behavior is coming from. Most behavior analysts train for and work with kids in schools, kids in special programs, development areas, kids on the spectrum, to try to make sure that they don't fall behind and that they can actually move forward in some of their functioning. They may work with OTs with some of the sensory issues that prevent kids from making easy transitions or handling stimulation or those kinds of things. But basically, they are behavioral specialists whose job it is to know what is the function of behavior, and based on that, which is kind of a root cause for why is the behavior happening, to be able to put a plan together that positively reinforces and supports that individual and the folks around them knowing and having training in how to do that consistently so they can get the best from the person. So in our world, we are preventing negative behavior from occurring in the first place, or once individuals show what we describe as treatment interfering behaviors, that we can undo that. And oftentimes it's a matter of, in the old days, we used to talk about this was a cry for help, what the person was doing. Now we really understand that that's a person's desire for connection, that they may be bored, or they may be anxious, or they may be scared and afraid, and they need some way of knowing that they're safe. And sometimes they'll test the staff on that, or just do things that they know they've been conditioned that it's going to bring staff to them for help. And we have to undo that and help support them in other ways that are healthier. That can also be the reason why somebody continues to come back to us, is they feel like they have to escalate things or swallow something or tie something around their neck. They're described as suicidal. They come right back to us and then they feel safer again. But the long-term goal is to undo that in favor of communication, expressing themselves, getting the help that they need without having to turn to such extremes. So behavior analysts are great at figuring out what's the function of behavior so we can really address it positively.
Super interesting. Thank you.
Mm-hmm.
You're welcome.
All right, last call.
Mm-hmm.
We can send, Katie, I'll send you our contact information if anybody has further questions. And of course, they will have like a link. I don't know if mine has a link for careers, but you'll then know where to find us if you're looking for something. But good luck with your continued studies. And the cohort 1 is paving the way. We're almost done. So you guys are right behind us. So you can also use me as a resource for that too.
We'll see you in a couple weeks.
Yeah.
Thank you both so much for being here and sharing with us tonight.
Our
Thank
pleasure.
you, and take care.
Take care.
Bye, guys.
Bye-bye.
All right. So let's take a 10-minute break if you guys are okay with that. We'll come back at, let's see, I got 7:02, so let's come back at 7:12 and we'll reconvene with your presentations. Okay, recording again. Okay, can everybody see the slide deck? All right. So Patrick and Becky, you guys can take it away.
All right. So we did the physician dismisses nursing assessments and the question of nurse advocacy case. Next slide, please, Katie. Our agenda, we're going to touch on the scenario. So we're going to present the background and facts of the case. We're going to look into the issue. We're going to dive deeper into the research and statistical facts, including misdiagnosis, malpractice suits, and residual effects of them. We did an analysis. And then, of course, we're going to take all this information and come to the conclusion and form recommendations. Next slide, please, Katie. So the facts of the case, the patient was brought into the ER because it was an accident. He laid his motorcycle on his left leg. They did a Doppler test. The nurses found no pulse. The physician that was treating him claims the pulse was there. So the physician also, later on, it was found that the physician also found bone fragments in the patient's x-ray, but he did nothing about it. He just sent the patient home. The patient began feeling worse. The patient went into a different ER, and that attending physician found that the patient had a lacerated popliteal artery and dislocated knee. So it was determined the patient needed emergency surgery, and it resulted in a 35-day stay. It was concluded in this case that full use of the leg would never be regained, and the patient ended up suing the original attending physician at the original ER and settled for $275,000 out of court. The patient decided to take the suit up also with the nursing staff at the original emergency room because, of course, they found there was no pulse in the leg, and they did not push it further and try to get the patient's care. So the council contended that the nurses should have done more, and the patient if the patient was treated sooner, he possibly could have saved the use of his limb. Next slide, please, Katie. So the issue was the nurses were guilty of breach of duty. So they failed to adhere to their obligation, which was to advocate for the patient. The nurses believed the patient was misdiagnosed, and the first attending provider did not reevaluate. So the nurses, because of that, they could have brought this up to the nurse management. They could have asked another ER doctor to evaluate the patient. They could have brought it up to quality improvement or the risk management team. None of that was done. So the first physician failed. He was guilty of nonfeasance, which at bare minimum, he saw the bone shards and did not treat them. And then, of course, the patient suffered a permanent injury. Next slide, please. So in diving into the research findings, we found that 5.7%, or 1 in 18 patients, or 7.4 million misdiagnosed cases are annually done in the United States ERs. 2 million cases actually resulted in preventable harm. 270,000 cases resulted in permanent disability or death. And then 40% of cases that were misdiagnosed are orthopedic. Factors include the patients being vague in describing their symptoms, ER providers being too busy to consider all the possibilities. They're just trying to flip those beds. Not enough tests ordered by the ER providers. And again, that could be because they are too busy or the patients are too vague. And then, of course, there's the sneaky conditions where they share symptoms. So it's kind of anyone's guess. And without those extra tests, who knows? Missed injuries, of course, part of the factors, and cognitive bias of the provider. I know I have personally encountered this where they think, oh, yeah, it's this. I know for a fact it's this. And they don't collaborate with other providers. And yeah, it turns out to be a mess. Next slide, please. Research findings. So the cost of all this, $100 billion annually. This includes lawsuits, extra testing, additional hospital stays across all specialties, as what happened in our case where he had to have a 35-day hospital stay at a different hospital. So that's all included in the $100 billion cost. $5.72 billion just in malpractice misdiagnosis claims are paid out annually. $297,709 are settled out of court for emergency room misdiagnosis malpractice. $816,909 is the average amount awarded at trial for ER misdiagnosis malpractice cases. And 31.8% malpractice cases are paid according, for misdiagnosis and the highest rates across all specialties. Next slide, please. So our analysis, Patrick, you're on the analysis, right?
Yep.
Okay, good. I'll turn it over to you.
So in our analysis, we were looking at a potential breach of duty from the nurse, and then also resulting damages from the breach of duty. Nurses have a duty to accurately assess documents and report abnormal findings. The possible breach would have occurred when the nurses did not escalate up the chain of command after the physician dismissed concerns. Evidence supporting damages included a prolonged circulation, which led to permanent tissue damage and nerve damage in the patient's leg. And then also that it required emergency surgery, a 35-day hospitalization, and then ultimately a large loss of leg function. You can go to the next slide. So we found that the nurses did fulfill their duty to assess. They met their initial duty. They assessed the patient's leg. They used the Doppler. They documented their findings, and then they reported their concerns to the physician. The next part of that would be if they did enough after the physician did dismissed their concerns, to which we found that they partially did. They questioned the physician, but the persistent findings on the Doppler, the negative Doppler, as well as the severe symptoms that the patient was reporting, should have required mandatory escalation using the chain of command. Yes, they should have gone over the physician's head. They have the legal and ethical duty to advocate for the patient when their safety is at risk or when they believe the patient's safety is at risk. Um, and the failure to escalate could and should be looked at as a breach of duty. Um, and then overall, legally, the physician was found guilty of nonfeasance and settled in court. Um, and then the nurses, they gave proper assessment, but would be deemed negligent for not escalating, despite the clear signs that the patient showed. You can go to the next. So a couple recommendations for how we could better this in the future. One would be to strengthen the utilization of chain of command, making mandatory escalation protocols for absent distal pulses, um, out of proportion pain, um, and severe pain, and then also discrepancies between nursing and physician findings. I think that's a big one. Um, and requiring documentation of each step in the escalation process as well, so that there's a record of it happening and there's no confusion surrounding that. You can go to the next. And then a second recommendation would be to better some of the interprofessional communication standards, whether that's increasing utilization of the structured communication tools like the S bar and critical value alerts, and just increasing the mandatory reporting of those. Another way would be requiring joint reassessments for limb threatening injuries. This would be done just to add another layer of protection for the patients, and then promoting more of a culture where nurses' concerns are taken seriously and receive immediate consideration, and especially when it's regarding a vascular case, an orthopedic case, or a trauma case. And you go next. These are references. That's it.
All right. So, thoughts, discussion, ideas on this?
It's a hard situation when you're a nurse and a physician is telling you one thing and you're supposed to go against him. Especially in like a critical situation.
Yeah,
That's going to be a really hard
uh,
thing, but I think, escalating it to your charge nurse and then she can go up the chain would be the right thing to do.
mm-hmm.
And I
Absolutely.
suppose, some nurses, they might think, am I crazy? I didn't see anything, or I didn't hear any pulse, but he's hearing a pulse. Is he more I can just assume that this is going back and forth in their head.
Mm-hmm.
Absolutely.
I think it's one of those situations where it's kind of like you're damned if you do and you're damned if you don't. But I think
Mhm.
when it comes to any sort of health concern, especially with a patient, and you have second doubts, then you definitely have to go up that chain of command. So I can understand to some degree why the nurses would have been deemed negligent in that case.
Mhm.
Because ultimately, I think they should have gone to the like higher order physician or charge nurse to tell their concerns.
Yeah, I was just going to say this escalation process you guys proposed, I think is a really great recommendation. And this would definitely be something that should be implemented. Lots of ethical considerations here and yeah.
Well, and it depends sometimes when, like, if it happens overnight on a Friday
Yes.
night, risk and, is not always at the hospital at midnight. You know what I
Yeah.
mean? So you would probably have to page someone on call, and it's like this whole, thing,
Yeah.
dog and pony show that
I
you have to
feel
do.
like,
But
these type of things always happen at the worst time when
Yeah.
the
absolutely,
administrator or somebody, of course, is not there when it happens and gets screwed up somehow.
yeah,
Yeah.
that's when it always goes awry.
Yeah. Any other thoughts?
I think it was great. Good job, you
I
guys.
I think so
Well,
too.
thank you.
Yeah, nice job.
Thank you.
Yeah, very well done. Okay,
All
next up.
right. So our case study was a proposed merger gone bad, and it was presented by me and Dominic. Next slide. On our agenda, we have a slide about background and context, the cultural shift and internal tensions at Beaumont Health, the merger proposal, the stakeholder backlash, delay and termination, and lessons learned. Go ahead. So, Beaumont Health is recognized as the largest healthcare system in Michigan, generating 4.7 billion in annual revenue while operating 8 hospitals and employing more than 38,000 staff. Leadership has played a pivotal role in shaping its trajectory, with the CEO, John Fox, MBA, joining in 2015 to oversee the merger of the 3 systems and to try to stabilize the budget. His compensation reflected the scale of the organization, totaling 5.93 million in 2018 and 6.75 million in 2019. However, controversy arose in 2020 when Fox received a 2.6 million bonus just weeks before Beaumont sought a financial bailout. These details highlight both the immense scope of Beaumont's operations and the challenges of balancing financial decisions with public trust. Next slide. In recent years, Beaumont Health experienced a noticeable shift in priorities, with financial performance increasingly emphasized over clinical excellence. This change reduced physician autonomy and led to the displacement of many private practice doctors, sparking concerns among employees and physicians about where is the company going with this, and a diminished focus on providing the best service to people. Cost-cutting measures forced experienced practitioners to make room for Beaumont employed doctors, which is always tends to be a cheaper option if the hospital can employ the physician versus having a contract physician. And the strain was compounded during the COVID-19 pandemic when the system furloughed 2,475 workers and permanently eliminated 450 jobs, underscoring the tension between financial pressures and the organization's traditional patient-centered mission. Next slide. In June of 2020, Beaumont Health announced a non-binding letter of intent to merge with Advocate Aurora Health, creating a 3-state system spanning Michigan, Illinois, and Wisconsin. CEO John Fox outlined ambitious goals for the partnership, including growing Beaumont's market share, leveraging the strength and scale of a larger regional organization, and making greater investments to inpatient care that could be achieved independently. As part of this vision, the proposed merger included a 100 million investment in new technology to support public health initiatives and chronic disease monitoring, underscoring the strategic intent to combine financial strength with expanded clinical capabilities. Next slide.
All right. So there was backlash associated with this merger, and physicians and employees really opposed the merger pretty publicly and argued that it didn't really offer any real economic benefit for Michigan, and it actually risked a loss of local control and would divert funds away from local hospitals and communities. So a petition began to circulate, and it was signed by hundreds of employees and physicians, and they basically asked the board to fire the CEO and stop the merger entirely. And the petition was, or it had some description in it that was like a rapid and progressive deterioration in every aspect of patient care, which is pretty significant to hear from the people that are providing firsthand care in the hospital. And others also voiced even stronger frustrations, and some of the staff accused leadership of caring um, about more personal gain rather than patient outcomes. And letters from physicians pointed to departure of key doctors, focus on profit over quality, and a total loss of confidence in the executive team. We can move on to the next slide. So, in response to this outrage, Beaumont's medical staff leaders decided to measure exactly how the employees were feeling. So, there was a survey conducted of about 1,500 physicians, and they showed that 70% of them disagreed that the merger would enhance compassionate care, and 76% actually said they lacked confidence in leadership. And then there was another follow-up survey of 681 nurses that revealed an even more devastating number that was 96% said that they did not have confidence in the corporate leadership. So when your entire workforce really expresses this distrust, it becomes impossible to lead effectively at the end of the day. So for delay and termination, by August of 2020, Beaumont's board decided to actually delay the merger vote as resistance continued to grow in the hospital amongst the staff. The board's vice chair actually came out against the plan and warned that it would increase costs without improving patient care. Um, Major donors also stepped in and urged the board to postpone the merger until staff concerns could be addressed. And just 5 months after this letter of intent was signed, Beaumont officially ended the merger talks. So Fox thanked the employees and community members for their input and cited that the COVID-19 pandemic as the reason from walking away from the deal. So, some lessons learned from this case study. So, one of the first things is that financial goals can't come at the expense of mission and culture. And Beaumont's leadership achieved efficiency, but lost trust and motivation of its people. And the second thing is that leaders must really engage stakeholders early, especially physicians and nurses who represent the voices of patients. When they feel excluded, they can stop believing in their leadership's vision. And third, transparency and communication are truly everything at the core of this case study. If leadership had really taken the time to explain their strategy, invite some input from doctors and nurses, listen to concerns, they may have been able to save the merger and gain employee trust at the same time. And the last thing is about local identity, and that healthcare organizations exist to serve their communities. And when leaders lose that sight, no amount of corporate growth can really repair that damage. Perfect. Any questions?
Is Fox still there? No. Did he get ousted after this?
I think so.
Or did they
Yeah.
hang on to him for a while yet?
No, he was gone, I think maybe 1 or 2 years after.
Oh, wow. It's funny, Becky, because I wrote, "Where is Fox now?" Uh, I'm surprised he stayed on for even 1 or 2 years after that.
Yeah, I was surprised too, honestly.
Yeah.
Mhm.
You
There was
guys, oh, go ahead.
oh, I was just gonna say my mom is a nurse and she works for M Health Fairview,
Oh, yeah.
and they merged a while ago, but they were going to, I think this was actually during COVID too. They were going to merge with a healthcare organization from North or South
Healtheast.
Dakota. Yeah,
Healtheast. They
yeah.
bought St. Joe's and
Oh
then
yeah.
closed it.
Yeah.
That was mine.
Yeah. Yeah, they were gonna merge with them, and like everyone just kind of, you know, revolted against it, and they didn't end up merging. So it's kind of a similar case style in this case.
Well, and so James Hereford is the CEO of Fairview. He got a $3.8 million bonus while we're in the trenches for 2020,
Yeah.
COVID care. That
Yeah.
was a huge contention point for Fairview.
Wow. Angie,
Is it
isn't there? Oh, go ahead. Go ahead, Becky.
is it normal that CEOs get bonuses? I mean, isn't their regular pay enough? I know it's a really hard job and stuff like that, and you're managing all this stuff going on, but really a $3 million bonus?
So
I can't wrap my head around that. I mean, I would just
Mhm.
love to make what do they make, like 10 million a year? That'd be enough for me, right?
Well, I mean, we didn't even have adequate masks and stuff.
Right.
And
Yeah,
I mean, I think
exactly.
that was everybody's issue. Like, where did this money come from? If we can't
Mhm.
even get safe
Absolutely.
N95 masks for everybody, we have to reuse the mask.
Mhm.
It was uh,
Who's
a
getting him
hard
this
time.
bonus?
Well,
The
the board,
board.
I
The board.
suppose.
Yeah.
Yep.
Hmm.
Boards.
And
Yeah,
what's really
and are the
interesting.
that's another question. Are the boards so disconnected that they just I mean, who's on the board anyway? Are there doctors on the board? Are there bankers
That's
on the
what I'm
board?
saying.
Are
That's what
I
I'm
there
think it's a mix of everybody,
Yeah.
and they have to have been in a leadership position. So
maybe.
I think it's, someone from finance, someone from nursing, someone from physician care, just a combined group.
Yeah.
huh? It just blows my mind. I mean, it was like a war zone in 2020, and this guy's getting $3 million in bonus.
Yeah.
Yeah.
Okay, then.
Yeah.
I mean, when Fairview bought St. Joe's, we were given 2 weeks to figure out what we were going to do with our cardiology program. And we ended up moving to a sister hospital and working out of trailers in the back of St. John's Hospital, and then going to the university and doing our high dollar procedures there.
My God, it's just you can't even.
No, I mean, it
Wow.
was crazy. 2 weeks, that's what they gave us. But we all rallied in cardiology and brought the cath lab over to St.
Mhm.
John's.
Wow.
Mm.
I think that Angie and Dominic, you really captured as I was taking notes and things, listening to you, you really captured the yeah, the lessons, the very things that administrators need to consider and keep at the forefront here for these big mergers and big acquisitions and things. I know, Angie, I was thinking about M Health as well, and isn't there in the U, isn't there something going on with like a physician group as well
Yeah,
that I've heard?
there, so the university and Fairview were potentially going to split,
Okay.
um, but I guess it's kind of a mystery what's really going on. But I
Yeah.
guess the UMP
Hmm.
physicians that work at the university are willing to stay with Fairview,
Okay.
but the university doesn't want to stay with Fairview, so I'm not really sure what's
Oh,
happening now, but as of
interesting.
latest, the physicians wanted to stay with Fairview.
Yeah.
And
Something
I,
to,
I think it has to do with the state taking on the cost of the university, which is, very old, and
yes.
they need a lot of work done
Hmm.
in buildings. And I think that um, there's not a lot of cash flow that, Fairview has the cash flow to
Yeah.
potentially help that. So I think that's one of the big issues.
Okay. But something for you guys to keep your eye on. I think we'll see
Hmm.
more about this.
Hmm. Well, and I think that, one of the most important things is leadership must balance financial goals with the mission and culture, because
Yes.
sometimes, like you can't be, oh, why did you get a call back? Like, because they had to come in and, treat
Mhm.
an emergent patient. Sometimes this you have to pay those things
Yeah.
in order to maintain, your employees and make sure they're happy and they're provided well for.
Hmm. Hmm.
And I think some leaders are like, just what is the bottom line money wise? Well,
Absolutely.
you have to take in all these other factors before you just look at the financial aspect.
Yeah. And as I read the case study earlier too, like the bottom line seemed like all that was really kind of uh, spurring this acquisition or merger on.
Hmm.
So, yeah. Any other thoughts on this one? I think you guys did a really great job.
Thank you.
Hmm.
Thank you.
All right. Wow. This is a great night, you guys. Our guest speakers were really fun to listen to. Um, so this is this week. Uh, I I don't know if you all saw my email today, but I noticed that the peer review assignment wasn't due until next Sunday. Um, I hope you're okay. I changed the due date to this Sunday. I kind of want to get this mini case study assignment wrapped up. I took a look at the peer review assignment and it's essentially a Google survey. And I don't think it'll take you guys very long. So if possible, if you could get that in by Sunday, that would be wonderful. But of course, I understand you guys you have your other assignment due, your health system issues analysis paper is also due on Sunday. So if you need a day or two, that's just fine. But kind of like to get it wrapped up so I can grade it all and kind of keep everything uh, with Unit 6. So any questions on anything coming up? Okay. All right. I'm working on a guest speaker for the very last class. Somebody to talk on, sorry, I'm going the wrong way here. Somebody to talk on, I think, so Adam will be here talking about AI and innovation, but then I'm also working on a final guest speaker for our last session. So um, I sent a couple emails today, so
So we
hopefully
have 2 more classes.
yes, 2 more. Can you believe it?
No.
I can't believe it's already December. Like this year has just flown by. So, um, yeah, yeah. So,
Perfect.
um, I don't think I have anything else. If you guys have any questions, speak now.
I know where to find you.
Yes, you do know where to find me. Okay. Well, thank you guys so much for your engagement tonight and great job with your presentations and exploring both of those cases. I know they were pretty different, but you guys did a really great job capturing the key issues with each of them and what should be done. So thank you
Thank
very
you.
much. Yeah. All right. Have a great evening and
You
enjoy
too.
the rest of your week.
You too.
Thanks.
Thank
Bye-bye.
you.
Bye.